So, a very lucid talk which covered most of the points which we wanted to cover actually. So, I think the job has been made very, very easy. So, just going with the testing part. So, what we do when there are such mutations and why we're not able to detect it very early? Samir was requesting your comments to start. Previously we had so less exon 20, now we are having so many exon 20 patients. What is the main difference, why it is causing so many new?
So I think the changing the testing methodology. So previously we used to do only PCR and IFCs or like that. So nowadays more and more we are using NGS in each and every patient because the cost has come down and it is routinely available everywhere. And that's why because of the broad-based NGS panel we are getting more and more exon 20 insertion mutation positive lung cancer.
Yeah. Patients. So a very important message for the residents and the learning people that by the RT-PCR, COBA's version 2 Roche platform which we use for RT-PCR, that takes into account total 42 types of EGFR mutations only. That includes 5 types of EGFR exon 20 insertions. But there are 64 types of EGFR exon 20 insertions reported already. So how do you expect a test which is doing total 42 types of EGFR mutations to detect 64 types of EGFR exon 20 in addition to exon 18, 19 and 21? So that is the importance of doing NGS so that you can detect more amount of EGFR exon 20 insertion apart from multiple co-mutations which are there and not very commonly detected by doing a RT-PCR. So that is the most important part. Our incidence was for EGFR exon 20 insertion was just meager 1% and that has improved to around 8 to 10% of all EGFR mutations which we see. So that is a very important point and take home message for all of us. So now how to decide treatment options when we see a patient having EGFR exon 21 then also an association with EGFR exon 20 insertion. Rushabh boss, your comments on that, EGFR exon 21 plus exon 20 insertion at the same time at the baseline NGS, how will you approach, what you will see in the report as well?
Not only for this case, but now when we are doing more and more NGS, we are seeing much more co-mutations. And exon 20 is also known to have co-mutations commonly. So there are, everyone is still learning, but there are some pointers like what is VAF of both the tumors. If it is reasonably same, you generally tend to treat more difficult or more prognostically bad disease. So say for example, for the patient which you are telling, largely Amivantamab plus chemotherapy would cover both of them. Whether to give lazertinib with that or we don't have lazertinib any other TKI with that or not is something which we need to discuss. But if something is covering both of them, or sometimes you add chemo to targeted and cover both of them, if feasible, and if not, then probably VEF and the poorer prognosis one, which is what we're looking for.
Yes, it's very important. Again, take home points. When you are having co-mutations, carefully look at the report, discuss in molecular tumor board if feasible, if you have the facility for the same. Try to discuss with the seniors who are expert in that. Look closely at the variant allele frequency of both the mutations. If you see that a VAF of one is very high, other is small, still you can consider the treatment based on the higher VAF. But if you see, as Dr. Rushabh highlighted, if both are having somewhat similar VAF, you need to treat the bad prognostic one accordingly. So exon 20 insertion is present and you are finding exon 18, 19 or 21 along with that in nearly similar VAF, I think you will be treating as per the exon 20 insertion mutations, and the results we have just covered in the lucid talk that it becomes important to utilize Amivantamab in such patients. So Dr. Anshul, I would request again your comments in terms of when we are counseling the patients, what are the 3 or 4 main points in terms of toxicities and benefits you counsel to the patient? So think I am a patient who is going to be started on Amivantamab. How will you counsel 3 or 4 points in just very generic terms?
So sir, the first of all, infusion related reactions are something that are evident from day one.
Yes.
So that is something that the patients need to be very mindful of. We as physicians need to be very mindful of, and has to be explained in uncategorical terms that look, this is something that which will likely happen, the severity of which will perhaps be seen, and they need to have very close monitoring when you specifically give the first cycle. Despite the divided doses, in our experience as well, we have seen that.
Yes.
Secondly, that as the patients go, so any TKI or any bite now with these, the rash and diarrhea are the common side effects. But one specific ones that we have seen and we have heard others are the mucositis and the chipping of the nails, the skin adverse effects. Specifically people who do a lot of IT work and computer work, so it becomes very challenging for those people to live with these side effects. Although incidentally, and the experience is still evolving, but the patients who do have these side effects, they tend to do well in terms of their disease, but at times after a few cycles it becomes a little difficult to manage.
Yes, so very important points for counseling of the patients, because it is not easy to manage them when we are starting. So regarding the infusion reaction, Dr. Kaushal, I would like to get your comment. What is the dose infusion rate you start in most of your patients when you are giving the first infusion, day 1 infusion?
In day 1 infusion, I used to start 25 to 50 ml per hour.
Yes.
And before infusion, starting the therapy, I used to give steroids, Avel, and I have seen in my practice I think 3rd or 4th cycle also patients did not have any infusion reaction in initial 2-3 cycle, but 4th, 5th cycle they were having. So anytime infusion reaction can happen.
So it's an important point again. Pre-medicate well. It is an antibody, but still you need to pre-medicate it well. We don't utilize DEXA, we utilize hydrocort, Avil as highlighted by Dr. Kaushal, along with Rantac. That is the 3 medication drugs we utilize for pre-medication. 25 to 50 ml per hour in the first hour of infusion is must. Don't go beyond that. In real practice, we start with 25. We don't start with 50, though it is the recommendation to start at 50 because of the higher infusion reactions in our setups. 90% patients have some or other amount of grade 1 or grade 2 infusion reaction. However, it is not grade 3, grade 4 in 99% of the patients. I have not seen any patient completely discontinuing treatment because of infusion reaction, but it is a very common phenomena. You will need to be cautious, you need to explain it well and document that there will be infusion reaction. I document in that way. You are going to have some infusion reaction, be ready for that, so that patients and the caregivers are ready for that. Otherwise, they may become very apprehensive and discontinue a very effective treatment. So that is very important point that needs highlight. One more point, subcutaneous Amivantamab trials have already come. Hopefully we will be having subcutaneous Amivantamab in some time down the line. That will also change the way we treat our patients, and it will be much easier for us to utilize this treatment because it takes some amount of time, logistic issues and other efforts. So that is a very important point. So let's coming very quickly about the liquid biopsy part. Rushabh boss, when the patient is not having adequate tissue, sometimes we utilize liquid biopsy. Your comment on that?
So that is pretty standard of care.
Yes.
If you don't have tissue in sufficient quantity or there is QC failure due to some reason, and the patient is not keen for second biopsy, then liquid biopsy is the way to go. But I think that liquid plus solid is something which will evolve, and probably we will have to do both in most of the patients, because the heterogeneity is more covered in liquid biopsy compared to the tissue.
Yes, I think that is an important point, and the way we are evolving, I think we'll be needing both in down the line when the costs come down further, so that we can have both in our patients. One more point, which I was just discussing with Dr. Samir, are all exon 20 insertion mutations similar, or they are different in terms of response to the TKIs or some other concept?
So basically in last talk only, Dr. Anshul has mentioned there are 3 different types of exon 20 insertion mutation, like near helical, far loop, helical. So different mutations had some different sensitivity to mobocertinib, which was the previous TKI, which was approved actually and then withdrawn because of some efficacy issue. So, but now for Amivantamab, we have seen almost all types of exon 20 insertion mutations are responding. So I think that like importance of seeing the different exon 20 insertion mutation has gone now. and I think every mutation will respond if you are using amivantamab. So no need to see which type of mutation while using amivantamab.
So that's another important point. The mutations are exon 20, as I discussed, there are 64 types of exon 20 insertion mutations. These are different, but the outcomes with amivantamab are similar. So that is one take home point. Second take home point, since we live in a world where all patients will not be able to afford amivantamab, you need to select in which patients you can use to utilize TKIs. The generic TKIs are available and some there is an option. Any highlight on that point? Anybody can
So I think the starting ones, so from 751 till I think
746 to 752.
Yeah, so the initial ones they do have some response. I'm not sure about that,
Okay.
but the later ones they really don't do well.
Yeah. So the point.
Helical, yeah.
Yeah. So initial one, 746 to 751, they have some response to the EGFR first generation and the second generation TKIs. But if we have 768 to 772 exon 20 insertions, they have some response to poziotinib and mobocertinib. Both are now not available even on compassionate access. We have the data for both poziotinib and mobocertinib. We have utilized poziotinib in more than 10 patients, mobocertinib in 7 patients, and we have seen some decent responses, not very long sustained responses. But these trials were negative because they were not able to select the patients. If they would have been highly selective, they would have shown some responses, but that is very important that amivantamab has activity across the exon 20 insertion mutations, and that remains very easy for us that we will like to utilize. So that makes our job easier and more utilizable in the direct practice. So if we
that data was like only single agent amivantamab. With now combination chemotherapy, it would be even higher.
Yeah, so this data for exon 20 insertion, where it is the data set was highlighted, amivantamab plus chemotherapy is now the standard of care and approved treatment option in the first line settings in exon 20 insertion mutations. So when we are utilizing, in some patients we tend to utilize amivantamab plus TKI also, especially in patients who are progressed on EGFR directed treatment in the first line setting based on the various data sets, since lazertinib is not available. Any point on that regarding any extra prophylaxis which we need to use, Dr. Anshul? Regarding the DVT prophylaxis, I wanted your comment here.
So this is something which is not highlighted as much.
Yes.
The real world experience amongst our peers we have come across that point that a significant proportion they might have DVT in various others. So I just was talking to somebody in the morning, and we had patients we lost because of cortical venous thrombosis, in patients having amivantamab. So in such patients, Eliquis or Xarelto prophylactically, although they are not recommended at this point in time, but it might be worth a discussion with the patient. And specifically, because once they do develop somehow, they tend to be very fulminant, and the course tends to be very progressive after that.
So again, take home point is that when you are utilizing amivantamab plus TKI or amivantamab not alone, it is along with chemotherapy, it is there is some recommendation evolving that you can add prophylactic drugs like Xarelto, that is rivaroxaban or apixaban, that we have started to do already, because in our data sets of close to 50 patients who have received amivantamab, we have seen one event. It's a one event, whether it is directly related to amivantamab or due to the concomitant comorbidities, we don't know. But even if one patient is having that, and that is already documented in other trials, we need to be cautious and we need to take that point in consideration. If there is no contraindication to prophylactic drugs, I think that remains the key. And also, when you are combining with TKI, for example, amivantamab plus lazertinib not available, so sometimes we'll do off-label combination with osimertinib. There it becomes much more important to add, because the incidence of DVT is much higher in those situations. So coming to another point regarding the importance of bispecific nature of amivantamab. So this has some MET inhibitory activity as well. So Dr. Rushabh, your comments when we are seeing the patients at the baseline, if patient is having some MET amplifications or anything, does it make more sense to utilize amivantamab?
Yeah, so it helps when if there are two mutations and both are covered, it definitely helps, and it is more so it is broader spectrum of action even for the EGFR component. Especially this helps more when you have post EGFR TKI progression. It also helps in that situation. So broader spectrum of action definitely helps.
Yeah, definitely. So that is
we
what.
know MATE is one of the important resistance mechanism to serotonin.
Correct.
That helps to cover that also.
Yeah, so that is another important point when we are utilizing drugs like Amivantamab, and we know that Amivantamab is able to cover both EGFR and MET, and that becomes a plus point for us, and that helps us. Another point is that some toxicities are MET related. Dr. Kaushal, I request to highlight the toxicities of Amivantamab which are somewhat MET related. Which do you think are important?
MET related, I think diarrhea is the common toxicity
Yes.
related to MET.
Yes, diarrhea and weight
Piles,
gain
yeah,
and
weight
fluid
gain.
retention are MET related specifically, which are seen. We have seen patients having significant fluid retention in the body, significant amount of facial puffiness, while creatinine is normal, albumin is normal. So that is a known phenomena, and that requires some amount of diuretics, some amount of counseling, active mobilization of the patient. That will help. So we should not be worried about that toxicity because that hardly causes anything else. But if the patient have been multiply pre-treated, sometimes we need to check the thyroid profile also, because that is what we see and importance. A very important last point which I wanted to take comment, Dr. Samir sir. Amivantamab role in brain metastasis. It is a large molecule which we think that might not cross brain, but your comment on that.
That was like our like thinking that it may not have good efficacy in the brain, but on the contrary, the data shows that it is having very good efficacy. In the intracranial response, it was around 70%.
Yes,
if I'm not
it's
wrong.
good responses, more than
So there was
50
a
to
good
60
response in the
percent.
brain also. So even in patients' brain mets, it will be helpful for us
Yeah,
to
so
use it.
it's very important comment and important and pertinent for the real practice. Amivantamab, though it seems that it does not have direct cranial penetration, but due to some altered mechanisms, we saw that there are multiple mechanisms, not only direct inhibitory activity, immune-mediated actions. It seems that the drug is able to cause responses in the brain as well. So don't think that brain metastasis patient you cannot utilize this drug. This drug has shown and documented to have very good responses in the brain. So I think with the available discussion and the data, it has become very clear that we can utilize Amivantamab very easily with some caution and training of the physicians. I think the toxicities will be there with any treatment. Otherwise, why there is a need of medical oncologist? So I will say that utilize the treatment well, even if it is toxic, so that you can manage the toxicities and control the disease in the best possible way. Thank you to all the panelists, and thank you to the audience. Thank you. Yes, please go ahead.
It's regarding your second point. So when we have concomitant mutation, we know that EGFR and ALK are though mutually exclusive, but there are cases which have been reported that both concomitant mutations have been found.
EGFR, where there is a case series from our institute as well. 22 patients of EGFR and ALK co-mutations. These have been published already.
So, sir, my question is, can you throw some light that how do you treat such patients? So, in among the two, do we have to see the VAF because both are major mutations? How would you like to give the treatment? So, this is my first question. There's one more thing.
So I'll be very brief so that I can respond in the first. If it is EGFR and ALK is a fusion, EGFR is a mutation. So you need to see both, but when there is a fusion driver, the fusion driver usually takes the upper hand. So if you have to choose only one TKI, you have to choose ALK. But if you are able to take both treatments, then I will prefer ALK plus EGFR combination, which we did in 80% of the patients with EGFR plus ALK.
Like 3 days, 4 days treatment.
Yeah. You have to give both. You have to give both together. Because, for example, you see, there is a combination data for osimertinib plus savolitinib. There is a combination data for other TKIs in combination. So why not, when you are getting two mutations which cannot be targeted by a single drug simultaneously, utilize both.
Okay. And the second question is, let's say since the liquid biopsy is coming up, so you have a patient EGFR mutated in the baseline, then you do a liquid biopsy after some time, and then you see another mutation coming up, which can happen because of tumor heterogeneity. So would you like to add the target right now, or would you like to do a tissue biopsy right now? Like, how will you proceed?
It depends on the credibility of the report. If you find and discuss in the molecular tumor board that the report is valid and the liquid biopsy is showing that mutation, you will consider adding it definitely. So if you are able to find that liquid biopsy mutation is already there, I think we'll not wait for it if it is already there. If you have done that, you have to act upon that. Otherwise, you should not have sent the test actually. So if you need to act, if you find the report, you will have to act. That is what I think, but it can be discussed with the patient at the correct time. Thank you.
Thank you, sir.